I'd like to share with you is the journey that I think we've been on, but I think the journey that many of the people in this room are on as well. And I think the journey that people will need to go through to deliver COBIC as you've heard about today. And it's a journey, I think, that it's an intellectual journey, it's an emotional journey, and it's a practical journey. And I think and the purpose of this club really is to bring people who are on that journey together to help each other through, as Bob and Paul have both said, what at times will be a difficult journey. It's a journey of exploration because it's been done in a small way, it's been done in some ways in other places, other countries, but we haven't done it here to scale. So we have a lot of issues and questions to work out together as we go through. And I think by bringing people together and an opportunity to talk and to share experiences and to I hope you'll lighten the load for each other and make that journey easier. So that's really what today is all about. So this isn't a story of an organisation, it's a story really, I think, more of both a personal and an organisational change that we expect will lead to a major transformation of services for the public. And so I think the first step on the journey is when we become involved with a commissioning organisation or take on a new responsibility with it or the leadership of it. I think the first step is to reflect on what the role of the commissioner is. It sounds obvious, you think we would know, but not judging by behaviour, I'd suggest. So I think the first thing is to recognise that it is an agency role. We're there on behalf of the taxpayer and the service user. We're there to represent their interests and to reflect their views and values, and there to deliver what they want from the huge investment they make in health services. It's a really easy thing to say, but I think that's not what's been experienced in the past. I mean, the public's relationship with the health service historically has largely been mediated through providers, not through commissioners. And I think a core job of the commissioners is to understand and reflect the views, values and expectations of the public to the provider system. And indeed, I think our value chain really is just turning taxpayers' money into better health, fewer inequalities, and making sure we have accessible access to high quality services. But that's not quite enough. It's about getting the best from the money that they choose to make available, and that's getting best value for services. So all those things are really easy to say, but it's what they actually mean in practice that I think is difficult. So I think the next step is probably to recognise that existing tools don't work. Commissioning has been around in this country for I don't know how many years now, but I think the general consensus is it hasn't been a fantastic success yet. And I suppose ultimately commissioning is nothing if it doesn't create change among providers. But Julia Smith at the Nuffield, I thought, wrote the best report I've seen on commissioning, which describes what actually happens, not all those nice theoretical circles of what I think we'll all be familiar with. It's been a process that has been expensive, it's been time-consuming and largely ineffective. And indeed, when you begin to think about the tools that we've got at our disposal, the contract form, if we are given, as we are as commissioners, a fixed amount of money for a population, and some outcome frameworks to deliver, I would suggest that activity, letting contracts and activity, is impossible to deliver your task that way. It's not just difficult, it's absolutely, the tool is not fit for the job. You can't translate, there's no metric that translates 800 outpatients to an improvement in health. You can sort of go, but looking at those spreadsheets, you can't understand the value of the commissioning. I think the next thing, again, easy to say, is actually to acknowledge and believe the scale of the change that's required. In our fabulous health service of 1.4 million people, I think that's about the number, we have huge numbers of talented and committed people. I mean, the majority of them work on the provider side, just so much bigger than the commissioning side. But they're largely organised around trades and not about the services that people need. The services and the experience of service we know is highly fragmented and people keep on falling through the gaps. As Paul commented, each bit of the organisation optimises its own bit and then loses value as people transfer between one part and another. And the net result is a huge voltage drop in the potential quality of care that the public could receive. And that voltage drop is poor quality is associated with a huge amount of waste as well. And my favourite classification of poor quality is the Institute of Medicine's classification: overuse, which is waste; misuse, which is waste; and underuse, which is waste. And if you attempt to quantify that, it's present in lots of different countries, but there's no easy metric, but most authorities would estimate somewhere between 20 and 30% of the total resource going into healthcare is wasted in the way in which care is delivered. Not just the administration, but actual delivery of care. And so, step back again and think, what's coming? Who are our major client group? And you just look at the demography, and our major client group in the future is going to be older people with multiple conditions. And then you just look at what we've got to try to meet those needs. We've got social care in one place, we've got community services over there, we've got mental health services somewhere else, and we've got our physical health services largely organised by noses and ears and kidneys and what have you. And you think, that just can't work. And that's true, it can't work. It has to change. And that's quite scary, thinking about the scale of the change that's going to be needed. And then I guess what's even more scary is thinking, well, actually, the provider side aren't going to do it by themselves. It's going to be down to us as commissioners to make that change happen, to be the catalyst to bring that change around. We need to commission in a way that unlocks the innovation and the ability and the knowledge that sits on the provider side and enables it to create new services, bringing in new partners, supporting more self-care, as well as getting better integration of services. And all of that seems to me to be a scary challenge. Is we can look at it and say, as we've all said it 1,000 times, but it's what we do with it next. And I think, in a way, that this is the personal bit, the emotional bit about it, is that the next step needs to be a sense of commitment. It's a personal decision, it's an organisational decision. We can choose to leave it to somebody else. We can choose to hide in the middle of the pack. We can choose just to take the stuff and do what we've always done. Or we can decide to do something different. And again, what's fantastic about this room is this is largely made up of people who have made that decision, who are determined they want to do something different. It requires a sense of bravery and a sense of courage actually to work against the stream. And when you go out into your own communities, your providers will sometimes look at you if you've got 3 heads, or as dangerous as an accident murder as far as they're concerned. But we need to act responsibly, thoughtfully, in a determined way, be practical and intelligent, but be decisive and act with pace and at scale. Again, all easy things to say, but need real action to follow them. But the first stage has to be that commitment, because unless we make that commitment, we'll get deflected and it won't work. We know, though, that this is the sort of the thoughtful and the intellectual bit, from looking at the evidence from around the world, that there are things that if done simultaneously, or if happened simultaneously, would make a big difference to reducing the waste and the poor quality that's there. Everyone knows about reducing fragmentation, delivery of improving integration. We know we swim in seas of data that we rarely use properly or to its full extent to help guide, to understand what we deliver, where we deliver it, how we deliver it, who to. And there's a huge volume of evidence. There's a big gap, isn't there, between what the research evidence says should happen and what actually does. But we don't make it easy for people to access and use that evidence in clinical practice half the time. The way in which we engage clinicians is often has turned what should be a resource and our strongest allies into confrontation. Partly through, I would suggest, through the nature of activity-based contract, which meant commissioners had to write detailed clinical service specifications, often usurping what might more legitimately have been thought of as appropriate clinical decisions. And again, we are the public's agent, this is the public's health service. We really need to make sure that it is the public's values that drive the outcomes that we seek, that help shape the design of services, and even down into consultation, it's the public's values that drive clinical decisions. And all the way through, the evidence is that if we are to make these sorts of things happen, it's really important that incentives for both individuals and organisations are aligned with the system's goals. And that's the big opportunity for commissioners. And that's what I hope and I believe that COBIC can do. That's the way they break into the cycle. So the tool, the next step is the tool of COBIC, capitated, outcome-based, incentivised commissioning. It is what it says on the tin, really. So moving from, it's identifying the population you want to capitate, identifying the outcomes, constructing the incentives, and then actually letting the contracts in that way and managing it. And there's lots of reasons that theoretical reasons that COBIC should work. I won't go through all of them, but I think you'll have the handouts. The capitation element strongly reinforces efficiency, but it allows, if you pull the money out across a segment of the population, it allows money to be invested not in the most appropriate place along a pathway, and not just locked up within a single part of the organisation. Just moving us into the practical areas. COBIC contracts are in theory easy to let. You just need to define the population you want to capitate, to engage with the public to make sure that the outcomes you're asking for genuinely reflect the outcomes that matter to them. You need to make an allocative decision to decide how much you want to spend on that particular population compared to others, old versus young, mental health and so forth. Tom's point about the duration of the contract, so 5 to 7 years we think is a good place to start. And then there's the commercial structure, negotiating the detail of the indicators, the transition from activity-based to capitation, and the details of the incentives. And there's a body of knowledge and practice that is emerging as we work with many of you and others, and certain patterns of ways of working, which I think we're keen to share and develop. And there'll be false summits as we go in some directions and think, actually, no, that's not the best way of doing things. And we'll come around and we'll learn. But the purpose of the club is to short-circuit that learning, so that not everybody has to go through the same pain sometimes or make the same mistakes, or work with people who found good ways of succeeding. We want to make sure they get passed on as quickly as possible. And again, this is really just to demonstrate that there is a process that's emerging, dividing the thing into different stages, and you need to understand timescale, the time that things take. And again, we want this club to help distill those processes, share those processes. And again, just emphasising the elements of skill and practice that go in to underpin a COBIC contract are similar, but not exactly the same as those that have existed or been needed for traditional elements of commissioning. I think we would say that the public engagement piece is something that is really, really important. You're really confident, and there are lots of vested interests in the room, but the one that you can't trump is that of the public, both as payer and user of service. So actually the moral authority of the commissioner comes, I think, from the quality of the relationship you manage to establish with that public. I think, and for me, that's an area that we haven't invested enough in the past as commissioners. People have already talked about the importance of engaging with the providers, both getting your existing providers to believe you're serious, but also the opportunity to let providers think about coming together in new forms of consortium. I mean, could you imagine an older people's service, which had elements of the older people's service, the mental health service, community services, APA, Serco, as a special purpose vehicle to deliver an older people's service? I think that's the sort of thing that there's some of the sorts of conversations that this sort of approach is likely to catalyse. Of course, it has to be done responsibly. I need to understand the money and the costs. And again, something that we have learned is that it's really important for the commissioners to have some idea about the doability of the ask they are demanding of their providers. And that means understanding something about being able to model the impact of different sorts of intervention, identify best practices from around the world. So when your providers come back to you and say, oh no, we couldn't possibly do that for that sort of money, and you can say, well actually we did this, this and this, that would get you all the way there. And by the way, actually, we think you can probably innovate and take the guild out. But actually, we're only asking you up to here, and we'll give you a transition process. But this isn't a lazy form of commissioning. It isn't just say, here's the money, you get on, do it, and we'll stand back. There's much more, I think, to encouraging and coaxing your providers to make the transformation that we all want to see. I haven't talked about actually that list, the development of the outcome measures. Again, comes from the dialogue with the public and then refined in dialogue with the providers. And that social process of the contract negotiation is really important, because it's in that social process that I think you can really align the goals, the aims, the perspectives of both provider and commissioner to a common purpose. And I think in that alignment, there's an awful lot of benefit. Procurement. There's a variety. Most places start nervous of thinking about competition as a form of procurement. But again, in our experience, as people work through, they become more interested in it. Whether it's sometimes competition between the community service or the acute provider, it's often how it starts to be the prime contractor, and then thinking about them coming together, and then thinking about, oh, actually, there may be some other people that we could bring in. So competition isn't the only form of procurement, but it's certainly one that we think has something to offer. There's also, with the longer term contract, the importance of transitioning risk over time. So you won't be able to collect all the data you want on year one, you won't know all the baselines and so forth. And again, it's something about managing risk sensibly and creating an ordered transition from where people are now to the future. And again, there's experience in that to be had both within this country and also from abroad. And of course, the contract has new data requirements, very different to old contracts, and we need to be able to build those in, and those systems of data collection, data flows, and data analysis. And again, more experience to share and learn. And then once the contract's let, of course, that's not the end of it. How it's managed makes a big difference, and that's already our experience from some of the places where the small COBIC type contracts have been let. And it's all those different bits of experiences that we want to capture, share, codify where possible, work with you to refine and to improve. And that really is the purpose of the club. At the club, it's focused to be people who are actually doing it, and we'll want to give access to people who are interested in the next steps. But ideally, we want people who are at or about the point of making that commitment to doing things. So it isn't the place for people to come and watch as the bystanders, but actually we want people prepared to roll their sleeves up and contribute and share. Because our aim is to make this a movement, because we do believe it's a mechanism for helping commissioners really add value for the taxpayer, really improve outcomes for individuals and for the communities that we are fortunate enough to be able to serve. That's really all I want to say. And other than a big thank you for being at the forefront and helping and joining us on this, which I hope will be an exciting and transformational journey. Thank you very much.